Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features content from an educational symposium titled The X Factor, Following the Science to Confront MDR, DTR, and XDR gram-negative infections, featuring Dr. Trevor Van Schooneveld as Program Director and Drs. Emily Heil and Laila Woc-Colburn as expert faculty. Dr. Van Schooneveld is a professor, part of the Division of Infectious Diseases at University of Nebraska in Omaha, Nebraska. Dr. Emily Heil is an associate professor of the Department of Pharmacy at the University of Maryland School of Pharmacy in Baltimore, Maryland. And Dr. Laila Woc-Colburn is an associate professor of the Division of Infectious Diseases at Emory University School of Medicine in Atlanta, Georgia. In this episode, they discuss approaches to managing complex clinical infections involving Carbapenem-Resistant Acinetobacter baumannii, or CRAB. For the full online educational program, including downloadable slides, please visit the link in the show notes for this episode. Now let's hear what they have to say about this topic as they start with the patient case.
This is a patient that was admitted to our trauma unit after a gunshot wound who has significant bowel injuries. He's gone back and forth to the OR multiple times. He's intubated and on CVVH at a reasonably aggressive flow rate of 3 liters per hour. On hospital day 10, he spikes a fever to 39.1 with worsening ventilator settings and a new onset leukocytosis. And his chest x-ray reveals an increased severe left lung opacity. VAP is suspected. A mini BAL is sent, and he started empirically on cefepime. But unfortunately, a couple of days later, we get the results of our BAL back from our microlab, and it is growing Acinetobacter baumannii. It is carbapenem resistant, so we are dealing with CRAB here. A couple of other things I'll highlight. It is Sulbactam intermediate, Cefiderocol susceptible with an MIC of 0.25, and minocycline susceptible with an MIC of 1. So keep this patient in mind as we go through our discussion. What makes CRAB so tricky? Unlike a lot of our interbacteriales, our non-lactose fermenters like Acinetobacter and Pseudomonas tend to have multiple different mechanisms of action at play versus potentially something like just a single beta-lactamase. When you're dealing with Acinetobacter baumannii, you're often dealing with multiple carbapenemases or other beta-lactamases such as ESBLs and AMCs. Our most common carbapenemases in our Acinetobacter species tend to be OXA23, OXA24, and then OXA58, like carbapenemases. You can see metallo-beta-lactamases in Acinetobacter, although that is more on the rare side. This is often seen in combination with things like upregulated efflux pumps that are kicking our antibiotics right back out of the cell, decreased outer membrane permeability, which is changing our antibiotics' ability to even get into the cell to begin with, or mutations of the actual drug target. And this comes into play as it relates to Sulbactam activity. You can see alterations in our penicillin binding proteins, which might impact some of the agents that we can use. And again, all of these mechanisms can co-occur, which can make these organisms especially challenging to treat. Beyond just our beta-lactams, though, we also see concomitant resistance with other antimicrobials, such as the fluoroquinolones due to topoisomerase modifications and the aminoglycosides due to 16S RNA methyltransferases. Other things that make CRAB a particularly pesky pathogen is that it is associated with biofilm formation. So we know that there can be resistant phenotypes and enhanced virulence when we're dealing with infections that are associated with biofilms. And as Trevor mentioned, similar to the Pseudomonas data that he presented, our mechanisms of resistance with CRAB can also be geographically specific. So if you're looking at data from a different country or a different region, the mix-up of resistance mutations and genetic similarity of the CRAB in that area may not actually be reflective of what's going on in your local institution. We've already mentioned that the 2023 IDSA guidance document offers a lot of wonderful information about how to treat these infections. One important thing to note, though, is that we're going to talk about a new agent that has just hit the scene for CRAB called Sulbactam durlobactam. And that was actually not out on the market when the last iteration of this guidance was published. So this guidance doesn't actually address where that new agent's going to fit into therapy, which is something we'll discuss about where it might fall today. As of the current guidance, which does not include that agent, it's recommended that moderate to severe CRAB infections be treated with combination therapy with at least 2 active agents, even if a single agent demonstrates activity, until the patient has clinically improved. And the backbone of that agent should be high-dose ampicillin-sulbactam, regardless of whether or not susceptibility has been demonstrated. They do also recommend using a higher dose of ampicillin-sulbactam than what is in the package labeling to get that higher dose of the sulbactam component, which is really what has our activity here. And then that can be used in combination with at least one other agent that has in vitro activity, such as polymyxin B, minocycline or tigecycline, or potentially cefiderocol, although it does have the caveat in the guidance that it should be limited to infections that are refractory to other options or demonstrate resistance to our other agents. So why is sulbactam our core component of our treatment against crab? It's considered a really wonderful agent for the treatment of crab because we know that at high doses, it competitively and irreversibly binds to PBP1A, PBP1B, and PBP3 against Acinetobacter baumannii. It's important to know that this is not interchangeable with other beta-lactamase inhibitors. This is not something where on stewardship rounds we can recommend changing from sulbactam to amoxiclav. It's really a unique component of sulbactam's activity. We know that sulbactam does retain activity against some strains that produce an oxo-23 carbapenemase, which is a really common carbapenemase in crab isolates seen in the United States. So there is some emerging data that it's dose-dependent effect and does not always hold true, but for a lot of strains that do produce that oxo-23, we still see that sulbactam has activity. It is important to know, though, that we do need to crank up our doses here. In other countries, you can get sulbactam as an individual agent, but in the U.S., it only comes co-formulated with ampicillin. And in that case, we are recommending off-label dosing to try to maximize that sulbactam exposure. And so that can be either for the moderate to severe infections, 9 grams of ampicillin-sulbactam, which gives you 3 grams of sulbactam per dose as a prolonged infusion every 8 hours, or 27 grams of ampicillin-sulbactam to get you 9 grams of sulbactam as a continuous infusion over 24 hours. One of the challenges that we deal with ampicillin-sulbactam is that because we're testing the combination together, really the MICs are a surrogate for sulbactam activity. And that's helpful when it's being reported as susceptible, but not so much when it's reported as resistance. So what we know from in vitro data and modeling is that at our kind of standard doses, you have a 90% probability of target attainment of achieving that time above MIC goal for crab isolates when it's reported as susceptible with an MIC of less than or equal to 16. But even when we're dealing with intermediate or resistance, where your MICs are in the 16 to 32 range, using those higher doses of the sulbactam recommended in this table can help result in adequate exposure, even at MICs of up to 32. It is important to remember, though, while our beta-lactams are generally considered safe, these higher off-label doses, we do want to be aware of the potential for things like neurotoxicity when we're giving them to patients. What about the combination of meropenem and colistin for Acinetobacter? This has been studied in 2 randomized open-label trials. The first was the AIDA study, and the second was the Overcome study. And both of these looked at the combination of a carbapenem plus colistin compared to colistin monotherapy in patients with multi-drug resistant gram-negatives. And in both studies, the majority of isolates were Acinetobacter. The first study had a majority of patients with pneumonia or bloodstream infections. And the second study, the Overcome study, most of the patients had pneumonia. And unfortunately, in both studies, they found that there was no difference in clinical failure at 14 days in the first study, or no difference in 28-day mortality in the second study in patients who got the combination of a carbapenem plus colistin versus just colistin by itself. Based on these 2 data, it's really time to sunset this combination, and meropenem plus colistin without the potential addition of a third agent is no longer recommended as a treatment option for crab in the IDSA guidance. What about a triple drug combination, though? Is this a winning triple threat? There is a lot of in vitro data that suggests that because polymyxins really help facilitate access for sulbactam and carbapenem into the bacterial cell, because they have that kind of detergent effect on the cell membrane, that you can see complete saturation of both your PBP1, PBP3, and PBP2 binding proteins. And again, these time kill studies really show very impressive increased killing with these triple drug combos. In a very small observational study, patient with colistin-resistant crab infections, 30-day mortality was actually 0% in 7 patients that got this triple drug combination regimen of meropenem, sulbactam, and polymyxin B, compared to 60% of patients who died with other regimens. That led our institution to adopt this triple drug therapy as our standard of care for crab. And we unfortunately had a large crab outbreak during the COVID pandemic. And so we treated all of our patients with this triple drug regimen up front. And we identified in our patient cohort no observation of resistance in patients that had recurrent infection with this early initiation of the dose optimized triple drug regimen. So the larger challenge is that there's just very little human data for these triple drug combos. They look wonderful in the lab. Our single center experience was pretty good with it. But at this time, IDSA guidance recommends against using high dose extended infusion carbapenems just due to that potential additive β-lactam toxicity, given the fact that we're using really high doses of the Sulbactam already and the very limited clinical data. So these triple drug combos are also something that's not currently recommended as a first-line therapy in the guidance. What about the role of tetracyclines? So we've got some pros and cons here. I'm going to start with the cons. So one of our challenges with our tetracyclines, specifically tigecycline, minocycline, is that our data to use these is almost exclusively in combination with other agents. So we have very little data about the role of like tigecycline monotherapy or minocycline monotherapy for the treatment of crab infections. The other challenge is that based on our in vitro data, it's very unlikely that we can hit our pharmacodynamic PK, PD, pharmacokinetic, pharmacodynamic targets, which for our tetracyclines is the AUC to MIC ratio with our standard dosing regimens. Beyond just that, we also know that there's PK/PD limitations of these drugs in general with certain sites of infections. So while they're really good tissue drugs, they have a huge volume of distribution. We know that they maintain very low levels in the serum, really don't get great levels in the urine, not really great levels in the ELF either, which can limit their activity at certain sites of infection. We also have very limited data for ravacycline with crab and essentially no clinical data for omadacyclines. When we're talking about tetracyclines for crab, really focusing on tigecycline and minocycline specifically. But it's not all bad. What are some of the pros? These may be a helpful part of a combination regimen, which is really how they've been most studied. I would say that one of the things we've learned from the in vitro data, though, is that their activity is going to be really most optimized when the MICs are low. So generally, you're looking for an MIC of 1 or less for both tigecycline or minocycline to see that likelihood of PK/PD target attainment. And we also want to be thinking about infection sites where we know we can optimize the PK/PD of these drugs, such as skin and soft tissue infections or osteoarticular infections. Probably not something I'd be reaching for in a patient that's got like a bloodstream infection, for example. The guidance document does recommend higher dosing as well. And for minocycline, continuing a dose of 200 milligrams every 12 hours, and for tigecycline, using a dose of 100 milligrams every 12 hours. With these agents, it's just important to remember that there are going to be some associated GI toxicities that can come along with this higher dosing. And then what about Cefiderocol? I think we all had really high hopes for Cefiderocol, the Trojan horse coming in and saving the day for Acinetobacter. Unfortunately, the data for Acinetobacter with this agent specifically isn't great. My colleagues will discuss that there are some other places where Cefiderocol might have a role, but we're going to kind of position this as more of a second line agent for crab. And that's really based off of the Credible CR study. Credible CR was a randomized phase 3 trial that compared Cefiderocol to best available therapy, which was most commonly some sort of polymyxin-based combination regimen, in patients that were infected with carbapenem-resistant gram-negatives that either had nosocomial pneumonia, bloodstream infection, sepsis, or complicated UTI. And I'll direct your attention down to the table. You can see that the overall all-cause mortality at the end of the study was 34% in the Cefiderocol compared to 18% in the best available therapy group. So Cefiderocol, not looking great, almost twice as much mortality as the best available therapy group. Now, if you parse this out by pathogen, you can see that this was really driven by Acinetobacter. So 50% of the patients in the Cefiderocol arm with Acinetobacter died at the end of the study compared to only 18% in the best available therapy arm. And for patients that had polymycrobial infections like Kleb pneumo or Pseudomonas aeruginosa, when you pull out those Acinetobacter infections, your mortality rates are almost identical between Cefiderocol and best available therapy compared to when the patients also had Acinetobacter. So really something was not looking good with Cefiderocol and Acinetobacter specifically. There was also the phase 3 Apex NP study, which compared Cefiderocol to high-dose extended infusion Meropenem for nosocomial pneumonia. Now, this study did not have a ton of patients with Acinetobacter in the study. But that being said, of the 53 patients that did have Acinetobacter, there was no difference in all-cause mortality at day 14 between patients that got Cefiderocol versus Meropenem. And again, this is in patients with Meropenem-resistant isolates, so you really would have expected the drug to work well at all. And so Cefiderocol was unfortunately no better than something that we didn't expect to work to begin with in this study either. Now, since then, there has been a number of retrospective observational studies that have come out describing more real-world utilization of Cefiderocol that are a little bit more promising. The largest of which that I've highlighted on this slide comes from a group out of Italy, and this was an observational retrospective study of Cefiderocol versus either colistin-containing regimens for crab infections, primarily pulmonary infections. And they actually found that Cefiderocol was associated with significantly lower 30-day all-cause mortality. What's interesting, though, is that the benefit here was driven by patients with bloodstream infections, and it was not observed in patients with ventilator-associated pneumonia. And it's also super important to note that almost 90% or more of patients in this study had severe COVID-19, which could impact some of the assessment of these outcomes. And on the flip side, though, Cefiderocol was associated with higher rates of microbiologic failure. So it does call into question some of that concern that's been raised with this agent about the potential for resistance on therapy or its durability as a single agent when utilized to treat serious infections with organisms such as crab. So just going back to our current 2023 IDSA guidance, as a reminder, our suggested regimens are going to be high-dose Sulbactam, even if non-susceptibility is demonstrated, in combination with at least one additional active agent, such as polymyxin B, minocycline or tigecycline given at high doses, or maybe Cefiderocol, but just with the caveat that's been limited to infections that are either refractory to other options, or if there's intolerance to or just resistance to other agents available. Things that we should probably be avoiding, really carbapenem-based combinations like Meropenem plus polymyxin B, Meropenem plus colistin, or some of our triple drug combinations, as we don't have enough clinical data to support their benefit, and they might just add other toxicities. They also mentioned that fosfomycin or rifampin are not going to bring much to the table as components of combo therapy, and they don't endorse the use of nebulized antibiotics as an adjunct therapy. Going back to our patient case and thinking about what we could start him on right now, based on the current IDSA guidance, we would want to use our ampicillin sulbactam backbone here. And then looking at our two agents that are susceptible, since minocycline is susceptible and that MIC was comfortably less than 4 and really 1 or less, which is what we want from a PK/PD standpoint, that would be a great potential regimen here. Cefiderocol may be an option, but again, because we do have minocycline available to us, the guidance does consider that more of a second-line agent. With all that being said, though, we do have a new agent that has come to market that is very exciting and may shake up how we are treating crab infections optimally at this time. Sulbactam, durlobactam, was FDA approved in May of 2023 for both hospital-acquired bacterial pneumonia and ventilator-associated bacterial pneumonia treatment. And it was FDA approved at a dose of 1 gram of sulbactam and 1 gram of durlobactam as a 3-hour extended infusion given every 6 hours. Durlobactam is a novel beta-lactamase inhibitor that was specifically chemically optimized to inhibit oxocarbapenemases. While it does have activity against some of the other ambler class beta-lactamases, including class A and class C, it was really chemically optimized to inhibit those ambler class D oxocarbapenemases. And when given with sulbactam, it lowers the sulbactam MIC by 32-fold against crab. This 1 gram of each component dose was validated in population PK studies that showed a target attainment for the AUC to MIC pharmacodynamic PK/PD target of 10 that was achieved for greater than 90% of patients when reported as susceptible. So the MIC breakpoint has been established as 4 or less. And this standard dosing has been associated with really high potential for target attainment at that MIC breakpoint. And there's also PK/PD data suggesting that there's a high probability of target attainment in ELF concentrations, which is really good news. We know that the most common site of infection for crab is pulmonary infections. And so we're looking for an agent that's really going to get excellent pulmonary levels to help manage these patients. So looking good so far with this agent. Now, it was studied in a phase 3 trial called the ATTACK trial, which was a multi-center randomized blinded non-inferiority study for part A. And then they had a second kind of Part B open label study that was for patients that had colistin-resistant crab infections. For Part A, hospitalized patients that had Acinetobacter confirmed pneumonia. So at the time of enrollment, they didn't have to know if it was carbapenem resistant yet. They just needed to know that the patient had Acinetobacter, either HAP or VAP, or bloodstream infection, were randomized to either the Sulbactam, durlobactam in combination with imipenem or colistin in combination with imipenem. And the imipenem was added to provide coverage of potential polymicrobial infections. And then patients were treated for 7 to 14 days at their clinician's kind of choice. Now in Part B, patients that were not eligible for Part A because they had colistin resistance or intolerance were just given open label Sulbactam, durlobactam plus imipenem. The primary outcome of this study was 28-day all-cause mortality in the modified intention to treat population, which is patients that had confirmed carbapenem-resistant Acinetobacter. And they were looking for a 20% non-inferiority margin. Key secondary outcomes that they looked at included 14-day all-cause mortality, clinical cure at the test of cure visit, and then rates of nephrotoxicity. Of course, because we are looking at a colistin-containing regimen, always trying to see if we can get something safer than that. In terms of the results, you can see here for 28-day all-cause mortality, their primary outcome, a difference of about 13.2%, although that did meet their non-inferiority margin between patients that got Sulbactam, durlobactam plus IMI, which is the blue arm, versus colistin plus IMI in the orange arm. You can also see that our rates of 14-day mortality were also much lower in our Sulbactam, durlobactam arm and higher rates of clinical cure. You can also see, not surprisingly, that patients that got the Sulbactam, durlobactam had much lower rates of nephrotoxicity than patients who received the colistin-containing regimens. They also identified higher rates of microbiologic response at the end of treatment and also test of cure visits for the Sulbactam, durlobactam compared to the colistin arm. In the Sulbactam arm did, unfortunately, though, have higher rates of recurrence, 10% versus 3%. So this is something that we're just going to have to keep an eye on in the future. But in general, from a microbiologic cure rate and a clinical cure, everything really favored the Sulbactam, durlobactam. I'll also point out that in the Part B open label arm, the 28-day all-cause mortality rate was 18%. It was 19% over here in Part A. So very similar rates of all-cause mortality between the two study arms, and very relatively low rates of mortality in general for Acinetobacter infections, with most literature showing rates of closer to 20 to 40%. So it did look good, with a clinical cure, a test of cure in the Part B group of 71%. So certainly our first randomized controlled trial evaluating a new agent specifically developed for carbapenem-resistant Acinetobacter, with some signals towards really promising results. One thing that I think is really going to come up as we have to try to navigate where this agent's going to fit into therapy based on how it was studied is, do we need to give it in combination with a carbapenem the way it was in the ATTACK study? One of the challenges is that we know that carbapenems plus Sulbactam are highly synergistic in vitro based on their complementary PBP binding activity. So we know that Sulbactam really prefers binding P1 and P3, whereas carbapenems pick up PBT2. And so when given together, you can really fully saturate the different penicillin binding proteins in our crab isolates. And can we attribute the positive findings of the ATTACK study solely to the SOLDER activity, or did that carbapenem bring anything to the table? Based on in vitro data, imipenem we know does lower the MIC of Sulbactam, durlobactam about 2 to 4-fold. We're just not sure of the clinical significance of that, but unfortunately that's how it was studied. At this point, we really only know how it works when given in combination with the carbapenem. One question that I do think is going to come up a lot is, can you utilize other carbapenems? There is some in vitro data that came out of ECMID that showed that Meropenem displayed similar activity to imipenem in lowering the Sulbactam, durlobactam MIC, and so probably could be used instead. One thing that I think is important to know is that from some of the in vitro data so far, it seems that this is really going to be most important with isolates either at the breakpoint or higher. When Sulbactam, durlobactam had an MIC of 4 or less, the impact of having this carbapenem synergy did not seem to be quite as significant. With all that being said, we're going to pause, and I'm going to have my colleagues, Trevor and Laila, come back and talk about our patient case a little bit and see what they would do. So I'm going to throw this out to you guys. Now that we can order Sulbactam, durlobactam, is that what you would offer for this patient, or are you still turning to one of our former high-dose lactam tetracycline combination regimens?
I guess that all depends on your availability of the drug at that time. If it needs to be given at the same moment, probably what you're going to do is your sulbactam and tetracycline while you get the other one. Now, if you have availability of the drug, I probably will go with it.
What about you, Trevor?
Yeah, I would agree. I think if you have it available using the agent, I guess the question that comes up then is, do you use that in combination with the carbapenem if you're using sulbactam, durlobactam, which I might consider, frankly. I think that's the challenge of the study you talked about, is how do we interpret that carbapenem use data?
Yeah, I think personally, I'm going to feel compelled to use it in combination with the carbapenem until we get more real world data. But I hope and think long-term that potentially sulbactam, durlobactam might not need to always be given with a carbapenem, but at least for now, I think that's the direction I would go in. I did want to pose a question to you guys. The guidance document says to use at least 2 in vitro active agents, but one of the challenges we deal with polymyxin is that we know that CLSI doesn't even tell you a susceptible breakpoint anymore, because based on the PK/PD of that agent, when used as a monotherapeutic agent, you can't give enough drug safely to kill crab on its own. But when it's playing in the sandbox with another agent, it tends to provide a lot of synergy. So how do you approach the role of polymyxin when using it in combo therapy for your crab patients?
I'm just not a huge fan of the polymyxins. And so if I can use a tetracycline, I'd really rather go that direction, if possible, as a second agent. That's just my preference. One of my mantras being try to avoid polymyxins as much as possible.
Yeah, not the same as Trevor, trying to avoid it. I think the problem comes when you don't have anything else. Can you just give it there? So if you don't have if you don't have the tetracyclines, and if you don't have anything else to give in combination, you're probably going to use the polymyxin. This is the part where if that's the only drug you have, then you're going to go that way. But if you have other drugs available to you, you will use the ones that have more data and have shown that have better effective killing, a better and less mortality at the 30 days and everything else.
Here's hoping we can put polymyxin to bed eventually now that we have newer agents available. To just wrap up crab real quick before I hand it over to Laila to talk about CRE, we really need to individualize our treatment regimens based on the patient's infection site, where we can optimize our PK/PD of the agents we're choosing, susceptibility testing results, and then our local epidemiology for crab. Our regimens probably should include a sulbactam backbone, whether that is the new sulbactam durlobactam agent with plus or minus a carbapenem, or sulbactam with at least one more in vitro active agent. I think as we get more and more data with the new agent, we'll see where it's going to have its place in therapy. But still, sulbactam, no matter the form it's given in, I think is a core component of our crab treatment. And our in vitro activity should not rely on susceptibility breakpoints alone. We know that there are issues and challenges with achieving PK/PD targets with our agents, especially like our tetracyclines, at the site of infection that we need to keep in mind.
Thank you very much to faculty, and thank you to our learners for joining in. To hear more episodes from this session on complex clinical infections involving gram-negative organisms with antimicrobial resistance, see the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.